Well, hello, everybody. It's quarter past, so I think we will start now. I'm sure people will keep flying in, but we can start with some of the housekeeping items. Welcome, everybody, to Data-Driven Improvements in Maternity Care, part of Clinical Audit Awareness Week. My name is Tina Strack. I'm one of the Associate Directors at HQIP. HQIP stands for the Healthcare Quality Improvement Partnership. I'm really thrilled to have a session dedicated to maternity care. I am the Associate Director at HQIP who has the maternity and neonatal portfolio. So I'm really passionate about it and great to see a talk specifically about that. Big welcome to everybody here. It's really great to see so many of you here today. Thanks for coming to the event, which is part of Clinical Audit Awareness Week 2025, running all week. Tomorrow is the last day, and we'll give you a little preview of the sessions tomorrow later on, and you can still sign up for those if you're interested. Clinical Audit Awareness Week focuses on the value of clinical audit and quality improvement in improving healthcare. I have a few housekeeping items to cover. I'll give you a quick overview of what we have planned for the day, and then I will introduce our first speaker. So I hope that sounds all right. Please feel free to share the event on social media using the hashtag CAAW25. We'd love it if you could tag HQIP, which is at HQIP on X or Blue Sky. And a big thanks to our Clinical Audit Awareness Week collaborators, including NQICAN. It's been really great to engage with our NQICAN colleagues all week. So a few more housekeeping items. We are recording the event, and slides and the recording will be made available online within a few days. Everybody's mics is automatically muted, and they will be kept muted throughout. I will be keeping an eye on the questions and answers at the end. I'll read out any of those. We would ask, if you can, to keep your cameras on. We are, after all, a community. It's kind of nice when you're presenting to see people's faces. Although I've just been part of an NHS providers workshop, and I kept my camera off, so no judgment if you do keep your camera off. Now, we have two things in Teams for the meeting. We have a chat and we have a Q&A function. We would ask that the chat is only used to report any technical issues. We'd ask that you keep the chat to a minimum if possible. And then please use the Q&A function at the end of the talk for your actual questions, which I will be keeping an eye on then and going through those. Quick reminder that all events and activities for the week, including award announcements for Clinical Audit Awareness Week, are on the HQIP website. I will try and put a link into the chat for that in a moment. Live events do require registration, but it's super quick. It's really, really easy. And there are still 2 events tomorrow, so do have a look at that. So in terms of the plan for today, we are going to finish at 3. The plan is I will introduce our first speaker, who I think is probably who most of you are here to hear from. We'll hear from them. I've got a few slides to present as well, and we will move into a Q&A, again, finishing at 3. So I hope that is acceptable to everybody, and it gives me great pleasure to introduce our main speaker. Dr. Eddie Morris is a Regional Medical Director for the East of England, a post he's been in since December 2022, and this followed his 3-year presidency at the Royal College of Obstetricians and Gynecologists. Dr. Morris is a consultant in gynecology at the Norfolk and Norwich University Hospitals NHS Foundation Trust, and an honorary associate professor at Norwich Medical School, which is part of the University of East Anglia. He took up his RCOG presidency in 2019, and during his term, he had COVID, so he covered the COVID-19 pandemic, rapidly producing RCOG COVID guidance, the call for workforce investment, and the need to address health inequalities. Prior to his presidency, he was RCOG Vice President for Clinical Quality and the Fellows Representative for the East of England on the RCOG Council. During his presidency, he also held the position of Vice Chair Standards at the Academy of Medical Royal Colleges, and he's also chair of the Multi-Professional Advisory Panel for Baby Lifeline. He's globally recognized for his work throughout his career in patient safety, standards and guideline production, and medical device work with the MHRA. He was the inaugural chair of the RCOG Patient Safety and Quality Committee and chairman of the British Menopause Society. He was awarded, very rightfully so, a CVE in the King's Birthday Honours list in 2023 for services to the improvement of women's healthcare and to patient safety. On a very personal note, Dr. Morris was part of I've known him since I started at HQIP. He was on an independent advisory group that I run, and he has always been an incredible source he's been a fantastic member of that group, And if I ever needed advice or was struggling with something, I know I could contact him, and he's just been a great, great resource for me. So massive thank you, Eddie, and I'm going to hand over to you.
Tina, thank you very much. My camera shows that I'm blushing. Thank you so much for that introduction. It's great to be here. Afternoon, everybody. It's fantastic to see so many people interested in this topic, which basically has been my whole life. I'm not going to go through this list, but if you know anything about clinical quality, you will know that that has been pretty much my life when you go down that list. And I have been proud to be involved with HQIP and the work that HQIP does over goodness knows how long now. But since 2014, I started the group. My own CV says that in front of my very eyes. So audit has been part of my life, but using it effectively, which I think is absolutely key. Next slide, please. I'm currently the Regional Medical Director for the East of England, and this is the official bit of what I'm supposed to do, and that's to lead within the region for my profession and that of pharmacists and dentists as well. But I have a specific focus on quality, safety, and driving transformation, but also supporting decisions behind commissioning, workforce changes, and supporting trust or any other provider within the region who are having problems. It's a bit of a catch-all role. I currently work for NHS England. Goodness knows who I'll be working for in a couple of years' time, but I hope be contributing still to healthcare. Next slide, please. The maternity landscape means at the moment that I don't have a leadership role in NHS England, but I still keep my finger in this pie that's been my 35-year career. But these are the current leaders nationally, if you need to get hold of them. The National Chief Midwife is Kate Brintworth, and the National Clinical Director and Obstetrician is Donald Peebles. And in the East of England, we have our own team, Wendy Matthews, the Chief Midwife, and Tej Kumar, our lead obstetrician. And there are 6 other regional maternity teams, all responsible for helping maternity to stay as good as it can be in the current NHS climate. Next slide. If you're a maternity system, you have access to several forms of support. From a strategic perspective, nationally, the Maternity and Neonatal Board that I sit on is the overseeing machine. I co-chair the Maternity Quality Performance and Surveillance Committee with a regional chief nurse from the Southeast, Andrea Lewis, and that's where all the data relevant to maternity that is commissioned by NHS England comes to for digestion. That can be staff surveys right through to commissioned audits performed by HQIP. And I'm going to talk about some of those in my presentation today. But maternity units can call on direct support from the regional teams, but also the Maternity Service Support Programme is a very specific support offer for units that are having difficulties, and they don't get to decide if they're part of it. The NHS England team decide whether they need that additional level of support, and that's pretty unique in the NHS. You don't see a support program for A&E or for orthopedic clinics. This is very specific for maternity because it is so high profile and actually, as I'm sure you're aware, very high risk. And there's also an early warning system in development that if we get time, we can maybe talk about in Q&A. Next slide. So why the interest in maternity safety? Well, it doesn't take long to Google. If you put the word maternity safety in, something like this comes up. And that is because it's a service within NHS England or within the NHS globally, or not globally, NHS around the UK, that is very vulnerable to changes in workforce, but also changes in how much resource it gets. However, even if you have the most fully resourced service, things can go wrong, and survival or not of mother, baby, or intact survival, so the baby remains healthy, depends on the speed at which the system responds. And for any of you who work in maternity safety, you will know that the Swiss cheese model of safety, where it only takes one thing in a whole string of events to negatively impact safety, the NHS is full of events that add up to a successful outcome. And therefore, it's very easy to lose sight of what led to an adverse outcome. And that's why audit in itself is really important, looking at processes. And you will know that there are lots of significant maternity investigations that have happened historically and are still underway at the moment. So they're very high profile, and it's up to us to make sure that the families and the babies that have suffered in these investigations are considered appropriately. Next slide, please. I'm a big fan of learning. The NHS is a learning machine. You may or may not know this, but data collection in maternity has been going on for years. It started initially back in the 1950s with the first confidential report into maternal deaths, and that covered a triennium. And that's pretty much the standard of looking at maternal deaths. And that's because the numbers of maternal deaths per year in the UK is thankfully low. So learning from a low number audit is quite a hard thing to do. But this is a confidential inquiry. So the notes of these maternal deaths were pored over by experts, and the conclusions delivered appropriately at that particular time. And bunching them up into triennia that move every year, it has been a very, very fulfilling way of getting high quality data so maternity services can learn. That Why Mothers Die was the next style of confidential inquiry that I used during my training in obstetrics and gynecology. And then we have MBRRACE here, which is the HQIP commissioned product from the National Perinatal Epidemiology Unit, who we'll talk about in a minute. Next slide. I first got seriously involved in confidential inquiries when the RCOG ran a confidential inquiry called Each Baby Counts. And this was the aim, a very high level, and we were criticised for being aspirational, that we were going to reduce the number of babies by half. We didn't. We didn't for reasons I'll talk about during this presentation. But what this was a confidential inquiry into baby deaths. And that's very unusual. We had every single unit in the country engaged in doing this. They were protected by confidentiality, so we're able to learn what the key impacts on baby loss were through those units. And those reports are well worth reading if you have the time and you're interested in this area. Sadly, Each Baby Counts stopped in 2020 because it was no longer commissioned and because of the small matter of a global pandemic. Next slide, please. So Each Baby Count showed, if you look at the main things, it showed that different care was likely to have made a difference to the outcome in pretty much 3/4 of cases over the 4 years that we looked at. And that is a significant thing to consider. Next slide. And the themes that came out of these reports, it's really hard to how to look at the themes when you've got so many things going on. But we created this thing called a blob to show that it's a whole interplay of different themes. It's almost never one thing that results in the loss or bad outcome of a baby. It's things like taking samples of the blood, it's recognizing the risk, it's team communication, it's human factors, it's education and training. And from that came a whole program of education and training, especially in human factors. So that was Each Baby Counts, a massive project in a nutshell. And I think there's still validity in continuing to look at confidential inquiries. Next slide, please. I also worked alongside at that time within the RCOG on the National Maternity and Perinatal Audit. I had a little conflict here because I had been advising HQIP on the NMPA, as I will now call it, before I became a vice president. But nonetheless, I took myself out of the commissioning process and wanted to deliver this project very clearly. So this is an enormous audit of NHS maternity services across England, Scotland, Wales, and it's using data that's collected in the background from the various patient record systems around the UK. The one thing the NMPA did really well was it demonstrated that at the time it started, there were 23 different electronic maternity systems across the UK, which of course is bonkers. And thankfully, in that time, a lot of work has been done to reduce the number of electronic systems down to a much more manageable number, well within single figures. I'm a big fan of collecting data that clinicians and midwives and busy people on the front line don't have to step aside and fill in. We had midwives that were checking that the data was correct, making sure that it was cleaned appropriately. But apart from that, most of the data is collected in the background, and that makes it relatively timely, but very high quality. And you can see we're looking at care processes, good practice, and areas of improvement. And again, do take a look at this because it's very interesting to look at the sort of things we're looking at. But I'll just show you a couple of ways. One example. Next slide, please. So here's a simple but very significant thing for many women looking at postpartum hemorrhage or significant vaginal tear. So we spotted in the audit that there was significant variation across the UK in the number of women who had these significant adverse outcomes. Next slide, please. And we presented most things in a funnel plot. Numbers were corrected for various demographic details. And you can see on the funnel plot, you've got outliers, and this is based on the number of deliveries. If you look at the bottom axis, you've got the number of term singleton births done per trust. So each dot is a trust or a Welsh board. And you will see there are some units significantly above the line. And we use this data to basically travel the country and show people, encourage them to look at their own data. We didn't do it in a pointy, this is your fault style. It was getting people to look at the data and to focus down where they could make improvements in maternity care. Next slide. The thing I'm going to spend a bit of time on is on stillbirth and neonatal mortality. I started talking about that and I'm going to finish. So, not finish on this, I'll cut the other things I'm going to talk about, but this is the one I really want to focus on. So stillbirth and neonatal mortality, baby loss. There is a national ambition to reduce that. And you will see from the plans, we are not meeting that ambition. COVID did some pretty bad things to so many areas of healthcare, and it did have a significant impact on maternity care. I could talk for ages as to what these reasons are, but many of them were workforce, some of them were the direct effects of COVID on women and direct effects on pregnancies generally. But nonetheless, even if COVID hadn't happened, there is evidence that we are still not meeting the ambition to reduce stillbirth. Next slide, please. So MBRRACE are commissioned to look at stillbirth and perinatal and neonatal loss. And this is the quality of the information they provide, which is extraordinarily high quality. It's consistent, it's legible, and it is now become a brand that clinicians, managers can use and use effectively. And I'm sure if you're involved in clinical audit, you will want anything that you produce to be instantly usable with minimal picking through the data to find the answers. And that's where MBRRACE excel. And we have here extended perinatal deaths, which is basically stillbirths and neonatal deaths, but we've separated that out into stillbirths and neonatal deaths. So you can see definitely the UK is making progress, but it could be much, much further on. Next slide, please. And also we look at the fact here that while stillbirths are decreasing, neonatal mortality rates, if you divide it up by the gestations at which the babies are born, are not improving. In fact, they're getting worse the earlier the baby. And because we have an increase in prematurity at the moment, that is a significant problem, a significant contributor to overall neonatal loss, and therefore that is an area that clinicians and trusts can focus on. Next slide. One of the things I really wanted to address when I was president was the ethnic disparities that we have in the UK, and this is really an item of significant national shame. I first saw really wide disparities when I went on a visit to the US as vice president, and I was pretty shocked to come back here and find that we weren't far off the US, and we have a national health service, and the US do not. And so you can see here there is a significant disparity if you are not a white Caucasian, and that is something that NHS England is very keen to address. Next slide, please. But it's not just ethnicity, it's also deprivation. If you live in one of the most deprived wards in this country, you have at least double the chance of your baby being stillborn in comparison to people who are in the least deprived quintile. Next slide, please. But what MBRRACE do is they create some really interesting graphs that basically allow you, graphics rather, that allow you to work out at a glance some quite complex statistical things. So simple folk like myself who are clinicians can look at this and don't have to concentrate on p-values, interquartile ranges and stuff like that. You can look at this line, you can say, okay, if you combine the most deprived Bangladeshi compared to the least deprived Asian Bangladeshi, you can see that the big blob means you have a much bigger problem than the smaller blob. Simple stuff. And when you're live on the website, you hover your mouse over that and it shows the size of the problem. Now that is really good 2025 graphics that make it very easy to people to look at that. And you can look at it by trust and an area of the country, because again, if you're trying to plan, you're a local person, me, a regional person, I want to work out where are the biggest problems in my region so they can focus their efforts most appropriately. Next slide, please. But it's all about turning data into actions, isn't it? When you're collecting high quality data, presenting it really well, there are things that you need to do. I've already talked about point one here, and that's planning services and getting them funded to deal with extremely premature babies. There's an argument there about trying to reduce the incidence of premature babies. So what is it about pregnancy that more babies are being delivered prematurely? And I know there's lots of charities working on that at the moment and funding high quality research. Thorough reviews of baby deaths to improve care. We've talked about those, like Each Baby Counts, but also HQIP oversees the perinatal mortality review tool, which really looks at a particular population of pregnant women at the contributors to loss of that baby. Sort of a bit like an Each Baby Counts, but not a confidential inquiry. And also helping providers use guidance. So that's all about getting the messages into guidance that's produced by colleges or for NICE or associations like BAPM, which is the British Association for Perinatal Medicine, but also those targeted actions that really run through all of these. Next slide, please. When it comes to maternal deaths, this is what the modern confidential inquiry looks like that MBRRACE do. So the other part of MBRRACE is they still do a triennial look at maternal deaths. So that design of confidential inquiry that started in 1952 is still there. And here we are more than 75 years later. And I think that's amazing. It really shows that the cogitations then were appropriate for the subject. And I remember working on the HQIP independent advisory group when we were thinking, well, how are we going to do this? Annually? Are we going to do triennial? Are we going to do 2 years? We stuck with triennial because actually there's a familiarity there as well as with the brand. And I'm not going to go through the report here because the important thing with MBRRACE is the quality of their graphics that make sense to clinicians and families alike. Next slide. Their most recent publication, which has come out extremely recently from the 2024 report, they produce key messages, and you'll see at the very top of the pregnant woman here, we have the fact that the biggest problem is blood clots, and so MBRRACE focus down on thrombosis and thromboembolism, and really point at where things could be improved and the recommendations they make recommendations are made with clinicians alongside. Next slide. To end, I'll just give you a real world example. So my current role is everything to do with medicine. So it's a big portfolio, I guess. As I hinted, it's medicine, pharmacy, dentistry, and lots of other stuff. So it's not just about maternity. And I try my very, very best not to get always dragged down towards maternity, but I think the way maternity uses data is pretty good. It's just a very complex, fast-moving area. But this is a real-world example as a medical director, and I've had to sort of anonymize this because it's quite recent. It's an active case, but it's relevant as to what tools are available to me where audit can actually help in the advice I give leaders in trusts. So, medical director in a trust contacted me and said, I've had a run of adverse events, and I don't know whether this is a good thing or whether it's a bad thing. Are we above the line? Are we below the line? Is this reasonable? And he open to medical directors are lots of interventions. They can stop the service as an extreme. They can take clinicians who might be having problems either personally or professionally out of the equation to help teams work better. but that medical director didn't think that they had the evidence at that point to have an intervention. So I had a telephone conversation, obtained some details of the cases, and I felt that they were of concern. They were high-profile adverse events. I suggested some early things to do that actually, to be honest, they were already doing, but it's a case of validating the early actions they'd taken. And then I hit the books. And the first place I went to was to one of the nationally commissioned databases that's out there. I'm not going to say which one because of the anonymization I want to do. But I remembered this HQIP database. I went to it. I looked at the number of this particular type of adverse event that should happen in a provider of this size. So a real back of the fag packet calculation, but I know I have faith in the data that's commissioned from HQIP. If it's covered, if a clinical area is covered by their data, then it's going to be relevant. And sure enough, that showed that this trust was probably having almost double the number of this specific adverse events for this specific patient group. And so I contacted the medical director. We both agreed that therefore something should be done. We didn't stop the service, but we did a lot of patient safety mitigations to make sure that that their particular service remained safe whilst the greater changes were happening in the background. Next slide, please. So my final slide is, so what does the data add? Well, I hope I've shown you how I have used it historically, how I use it today, the importance that the oversight that a body like HQIP gives to those that they commission data from, the way clinical advice is taken or wider advice is taken to make sure the quality of the information remains consistent and reliable. But I firmly believe that the central collection of data that is unbiased, is authoritative because of the high level of quality that it has, it becomes trusted. You can't trust everything first time round. You need to find its use and find its niche. And in maternity, it definitely has its use. There is no doubt about it. And therefore, it influences people on the front line, but it also influences policymakers, politicians. If I have to have an argument or a discussion with a politician or someone I need to influence who may not have maternity on the front line, I know I can go and get really high quality graphics that they will understand in a heartbeat. But as I said, collection of the data must not take a hit on the work of frontline people. They've got plenty enough to do. They don't need to be collecting data. And so far, so as I hope I've shown, this data is used to improve safety, quality in the health system. It also improves choice because people can look online and they can say, maybe I won't go into Trust A because it doesn't look very good. I'm going to go to Trust B. I don't think there's lots of data out there to show performance, but I think performance in safety is what our patients want to know as much as the experience they're going to have with their in a trust. So I hope that whistle-stop tour about my life and my experiences with clinical audit, its use and its effect on the health system has been useful. And I'm going to hand over to Tina now, but I look forward to fielding your questions later. Thank you.
Brilliant. Thank you so much, Eddie. That's been great. I'm going to very quickly just talk about, we thought, today's theme is about influencing change. And so I'm actually going to focus on MBRRACE and just pull out two examples of findings that were in the reports and how changes happened. Now they're small examples, but I think it shows that these programs do make a difference. I've just put this slide in for those of you who don't know about HQIP. We hold the contract with NHS England to deliver the National Clinical Audit and Patient Outcome Programme. And really importantly for the maternity programs, that is almost always UK-wide. So it includes Scotland, Northern Ireland and the Channel Islands. Next slide, please. I was going to spend some time explaining what the program is all about, but Eddie's covered MBRRACE really, really well. There's essentially two main streams of work. You've got a surveillance stream, which is really robust, epidemiological, high quality information about that's at a population level. And then they have the case note reviews, and that's what I'm going to focus on now. Next slide, please. I put this one in just because I thought it was so interesting that as we were getting ready for this talk, this was in the HSJ last week. So once again, shows the impact of the MBRRACE program. There was a news story about that one of the trusts in the country that has a high perinatal mortality rate is going to have some external reviews. So just thought that was very, very timely. Next slide, please. Thank you very much. So I thought I would talk about sepsis. So this came from the very first report that the MBRRACE team did back in 2014. And sepsis, for those of you who don't know, it's a life-threatening reaction to an infection. It's when your immune system overreacts to an infection and starts to damage your body's own tissues. And pregnant women are uniquely at risk from sepsis. And pregnant women can appear really well until the point of collapse. So there's often little warning in that. But more often than not, a woman's vital signs can give you an indication of the early stages of sepsis. Next slide, please. These were two case studies that they included that year that I think are really moving, and they show you the difference in care. So the one on the left in blue was a woman who sadly died, and the one on the right in purple is a woman who lived. And the difference between the two is essentially the first one's a woman who presented to her GP. There was no assessment made about the urgency at that point. She then went to the gynecology department. She was reviewed by a junior doctor, but it took nearly 3 hours for that. And the junior doctor didn't recognize the severity. They were seen by an obstetric registrar 6 hours after admission, and they were prescribed antibiotics, but they weren't actually given for another hour. And then by the time the seriousness of her condition was recognized, she was rushed, she was given the intensive care and given care, but she sadly died. Whereas the other example shows that this was a woman 7 days postpartum. She became unwell, went to the maternity unit. She was noted, those vital signs were noted. She was immediately prioritized for urgent medical review. They made the diagnosis of sepsis, prescribed antibiotics that were started within 1 hour of diagnosis. And then she was given care and she lived. So next slide, please. The big message from the report that year was to think sepsis. Almost a quarter of the women that year who died had sepsis. And what these women need is early diagnosis, rapid antibiotics, and review by senior doctors. Next slide, please. So what happened as a result? Well, one of the things that happened was in Scotland, NHS Education Scotland developed a maternal sepsis e-learning package. And this featured scenarios based on the vignettes included in the MBRRACE report. Next slide, please. The UK Sepsis Trust also developed a series of clinical toolkits. So there are, I think, 6 of these. Now, these were based on NICE guidance, and they were for different areas like out-of-hours care, community midwives. Next slide, please. And this is what these guidelines look like, and they can be personalized by any organization. So these were a great resource for pregnant women. Next slide, please. And I like to always give examples from all the developed nations. Next slide, please. Wales also updated their, there we go. They also updated their maternity sepsis screening and management. So I know that at the same time, there's been a lot of work going on about sepsis in the NHS, but I think we can really see that when there's a finding from these reports, there are actual tangible things happening. Next slide, please. I'll just very quickly cover the next topic, which is, this was in the 2019 report, and this identified preeclampsia as an issue. And the big message that year was that women with risk factors for preeclampsia need aspirin to be prescribed from 12 weeks of pregnancy. Now, preeclampsia is a not super common, usually fairly low risk condition, but if it gets serious, it is life-threatening for the woman and baby. Next slide, please. So the recommendation that year was to establish something called a national patient group direction that would allow midwives to supply aspirin to eligible women in line with NICE guidance. Now, a patient group direction is basically when you make available to an entire group of patients a certain prescription. They take time to develop, they're multidisciplinary, and you have to be really clear about who it's targeted at. Next slide, please. And it took a little bit of time, probably because COVID in between, but on the 9th of February, 2022, there is now a patient group direction for aspirin tablets for use within antenatal and maternity services. Next slide. And this is, I found this, this is a patient group direction online, and this is the document that an organization will actually take and use internally. Next slide. So what, has any of this made a difference? Well, it's a difficult story to tell, but next slide, please. Eddie had actually showed this as well. This is from the 2024 report, and this shows from that report what the main causes of death were. Next slide, please. If we look at sepsis, now back in the 2014 report, there were 83 deaths due to sepsis. Now, a lot of those were also, the flu had been part of it. So there was a call then to increase flu vaccine uptake with pregnant women. As I said, we know there's been a lot of work more generally around sepsis, but 25 women died. So it does look like things have made a difference. And it is about the system, isn't it? And this is just one piece of it. Next slide. I think we have one slide left. Q&A. There we go. So there we go. That is just some highlights of some of the things that I think show that these projects are making a difference. So in terms of the Q&A, I will go have a look at the Q&A questions. I thought I would start, Eddie, if it's all right. I'm going to start by asking you a question, which probably shows my own ignorance about how things work out in the system. But I was curious, how do you, as a regional medical director, sort of engage with trusts around data? Should they be sharing information with you? Should they be sharing data? Do you need your own access to data? How does that relationship work?
That's a very interesting question. I mean, from a regional perspective, we get a lot of data. So a lot of this data is performance related, workforce related, that actually is collected nationally and shared back to the trust. So we get quite a lot of their information. From safety incidents, there is sharing with the quality teams within region. So we do get that, but we don't. But there's a lag time with that, quite a significant lag time, because quite often trusts will, if there's been an incident, it'll be recorded on Datix, which is one of the commoner ways of recording patient safety incidents within hospitals. There'll be an internal review if it's a severe outcome. And after that, we will get to know. And so there is certainly potential for making that data from trusts a bit more responsive. And really, the rest of it is relying on them to share with us if they have a particular concern. We try not to be, as it were, too invasive from a monitoring perspective, because our job is these are big, sovereign organizations as foundation trusts, and they have responsibility to keep going, but to let us know if there's anything in particular that concerns them. But it's healthcare, and we know healthcare can change at the drop of a hat.
Fantastic, thank you. So we do have some questions, so I'm going to jump right in. The first one is very interesting, Eddie. I don't know if you have any thoughts on this. So it's essentially asking about your views on the current state of integrating maternal and neonatal data sources for informing national and regional local improvement efforts, and whether you have any thoughts about what the ambition should be around the integration of those two data sources.
Yeah, I mean, it makes complete sense. I mean, anybody working maternity feels that those data sources should be the same, shouldn't they, really? Because you can't have one without the other. And this is why we have nationally the Maternity and Neonatal Board. It makes complete sense. And at the moment, there are difficulties because there's been one big provider in electronic patient records for neonates for quite some time, but trusts understandably have moved to electronic patient record systems within their trust that may not necessarily be compatible with the long-standing leader in neonatal data collection, and so we have got a crazy situation where you've got special NICU nurses who are double entering data, and that is not a situation that we should be in. And in fact, I was at a meeting recently where that was raised, and that is something that really does need to be addressed, and that I'm sure will be within the work of what would have been NHS Digital, that is now the NHS England transition team. Transformation team, apologies, and that will hopefully direct those improvements because they do need to happen. So as you know, I'm a big fan of frontline clinicians not having to do more work to collect the data.
I can also share that there is a project that we are taking on in the audits, which will actually combine the maternity data from NMPA with neonatal data from NMPA, and that could be very exciting.
Great.
So that is in the works. Eddie, I think you hinted at this in your talk, and someone has asked a question about whether there's an update when the MOS data will be publicly released, and I wondered if you can say anything about that.
I can't give you a when yet, but it's definitely making progress. It's heading in the right direction every time I get an update. So Chelsea, you asked that question. Definitely it's making progress, and some units are using it already. And these things, especially with like real-time monitoring for maternity units, because of the implications of the data, it's really important to get that as right as it possibly can be. So yeah, it's definitely making progress. I couldn't give you a date though, in all honesty.
Thanks. That's really helpful. I think this next question is really interesting. And of course, I think in neonatal care, certainly what I've seen is that there is quite good about collecting patient feedback on the care that the baby was receiving. And I guess, I mean, I think it's a bit of a no-brainer, isn't it? The answer is yes. But is this something that should be included in maternity audits? But also, how can we collect that in maternity services? Any thoughts on that?
So I think the quality of patient feedback, there's definitely a place to improve that. Obviously, at the moment, there is the trusts collects friends and family style data themselves, but nationally, I think it'd be very good to have a better way of collecting it. I'm a big fan, though, of there actually being a way for patients to ask for their care to be looked at a bit like the oh crikey, just gone out of my head. Martha's Rule.
Yes.
So Martha's Rule in pediatrics has been rolled out pretty successfully around the country. And okay, that's a very extreme version of patient feedback where you've got someone worried about their care. But I practiced medicine for many years now, and I've never been afraid of someone asking for a second opinion after they've seen me or I've given advice. Why should I be afraid of that? I want people to feel happy and confident in the care that they're being given. And I think Martha's Rule has been rolled out extremely well. And I see no reason why something like that in maternity couldn't work alongside. But I guess my job is to work with people about making that feedback more accessible. But which did something similar, in which the Consumer Association, they did something similar based on feedback, a bit of almost like a TripAdvisor for maternity units. I don't know whether that product's still going, but it was very interesting whilst it was there.
Fantastic. There is one more question, but I think we've only got 2 minutes left, so I think I will wrap up the Q&A. Sorry, Jan, because it's a really good question. Maybe Eddie and I might write some answers in there. That has been absolutely fantastic. It's been such a pleasure to have all of you attend. Really, really, really grateful to Eddie for your time and for your insight today. This last slide shows you that Clinical Audit Awareness Week is not over. There are still events tomorrow. Please sign up. We'd love to see you on a lovely, well, very grey Friday here in London. It would be great. Thank you to everybody involved in Clinical Audit Awareness Week, NQICAN, the speakers, participants, everyone behind the scenes, and especially the award winners and everyone who put submissions in. I was a judge for one of them, and the submissions were fabulous. Big thanks to everyone out there on the front line, in trusts, health boards, for sharing, arranging events and activities during Clinical Audit Awareness Week. We're really thrilled to see it. To patients and carers, and importantly, everyone involved in clinical audit and quality improvement, and anyone I've forgotten, please do feel free to sign up to HQIP's mailing list to receive a roundup of all the resources after event. The link is in the Q&A for more information, and we'd love to receive your feedback. There is a link here on this last slide. So I think that is it for all the thank yous. Just to say again, thank you so much for coming today. It's been a real pleasure to have you, real pleasure to hear from Eddie. And thank you again. And we'll see you tomorrow, and then we'll see you next year. Hope you enjoyed. Thank you.
Thank you.